All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. We had a couple-week break here, and we're ready to get back into it. Today we have Dr. David Bakal and Dr. Jacob Davis, both fellows at Emory University currently. Dr. Davis is originally from Northern California. He did his residency in family medicine at LSU in New Orleans, and he did his medical school training at Ross. Dr. Bakal is originally also from Northern California. He did his residency in physical medicine rehab at Stanford and medical school at UCLA. Today, they will be presenting on a rectus femoris injury.
All right, thank you. Let me try and share my screen. You guys able to see that?
Looks great.
All right, let me just. All right, so yeah, we're going to be presenting today on proximal rectus femoris ultrasound evaluation. So some objectives, we're going to start with a case presentation. We're going to spend a good amount of time talking about the anatomy of the proximal rectus femoris muscle and tendon. We're also going to go over an ultrasound evaluation of the normal proximal rectus femoris muscle and tendon. We're going to talk about some common pathology that can happen there, as well as the ultrasound findings. So to start off with the case, this was a 15-year-old male soccer player who came in 6 days after experiencing sudden onset right anterior hip pain after kicking a ball in a game. His exam, he had an antalgic gait, he had tenderness to palpation over his AIIS, he had limited hip range of motion due to pain, and he had some weakness with resisted hip flexion on the affected side. So when someone comes in and we're thinking about doing an ultrasound and they have that anterior hip pain, there is this whole checklist from the AMSSM website. We're really going to be focusing today on the rectus femoris tendon muscles, what they should look like normally, and what are some common pathologies that can happen in that area that you should be thinking about. It's a fairly in-depth topic, and that's why we're kind of focusing on this. So to start off, just so everyone's on the same page, just about the quadriceps. So there are 4 quadricep muscles. 3 of them start off on the femur. So you've got the vastus medialis, the vastus lateralis, and the vastus intermedius. The only one that originates on the pelvis is the rectus femoris. And in this talk today, we're just going to be focusing on the proximal rectus femoris. So this portion right here. So we'll blow up that image a bit and then walk you guys through this slide and what we're looking at. So the proximal rectus femoris has 2 heads. So there's a direct head, which is here in yellow, that originates on the AIIS. And then there's an indirect head that originates at the superior acetabular ridge and kind of has that curved shape. The 2 of them combine to form something called the conjoined tendon, and that's about 1 to 2 centimeters distal to their origin. That's this green structure right here. And then to go a little bit more in depth, so again, we said that direct head is originating from the AIIS. It actually comprises the superficial component of that conjoint tendon. So again, the fibers of the direct head are really more the superficial part of the conjoint tendon. And then they blend anteriorly with the muscle's fascia as they travel a bit distally. So you can follow its course, kind of just the yellow portion and the superficial part of the green spot there. Whereas the indirect head, we said, starts on that superior acetabular ridge. It comprises the deeper component of that conjoint tendon. And then it forms this deep myotendinous junction that extends about 2/3 of the muscle belly of the rectus femoris. So you can follow its course here in the blue. And when we look at that with axial slices, I found this diagram to be really helpful and walk you through it. So the direct head here is this green originating on the AIIS. We said it's the superficial component of that conjoined tendon. So when we're looking at an axial slice of it, it's just that green, the top superficial component of it. And then we said it blends anteriorly with the muscle's fascia, and you can see that as we start moving more distal. it remains anterior, but by the mid portion of the rectus, it has disappeared. The indirect head, we said, is this yellow one here, starting from the superior acetabular ridge. It comprises the deep component of the conjoined tendon, as you can see it here. And then it forms that deep myotendinous junction that goes about 2/3 of the way down the rectus femoris. And on these axial slices, you can see that it's still pretty pronounced. Another important point is that it travels along the medial portion of the muscle belly. So again, this is lateral, this is medial. It travels along the medial portion. So important to remember when you're looking for pathology. That's kind of some basic anatomy. Now, how does this look on ultrasound with a normal evaluation? So we'll start with the direct head in long axis. So remember, the direct head starts on the AIIS. So if you're thinking about this, this is an ultrasound probe. We're looking at it in long axis with an actual person. The way that we typically found it was the easiest way to find it was by starting the ASIS in short axis, scanning distally until you find the AIIS, and then flipping 90 degrees to get the direct head in long axis. And this is an image of one of our other co-fellows, Proximal Rectus Femoris. So I always think it's helpful to kind of compare the image here to what you're expecting to see in the diagram, and I think this one corresponds pretty well. So your AIIS is going to be this bony prominence here. The direct head is going to be inserting onto it. You can see in this case, the fibers look well aligned. There's no hypoechoic areas, no areas that really seem like there's a partial tear. These kind of shorter arrows coming down here actually correspond to the indirect tendon. So this isn't a fluid collection. It's just kind of the way the shadowing works as they start traveling distally. And then overlaying this is the iliopsoas muscle. So now looking at that in short axis, so with our ultrasound probe directly over the AIIS, what do we see? So again, the AIIS is going to be this bony structure at the bottom, and the direct head is inserting directly onto it, denoted by the arrow. We still have the iliopsoas superficial and a bit medial, and the sartorius is the most superficial muscle structure that we see here. As you're evaluating it, you can scan proximal and distal a bit. It's not an incredibly long segment, but as you do that, you can look for pathology within the direct head, seeing if there's any areas of partial tearing or calcifications. We'll get to that a little bit later in the talk, but again, this one looks fairly normal. So ultrasounding the indirect head is a bit tougher just because it's so deep as it's inserting onto that superior acetabular ridge. Ultrasound probe position would be here. And when you're actually scanning, it's much more lateral than you would think. That was something that surprised us as we were preparing for these slides. I'm going to start with an image from a paper, just because I think it helps explain the anatomy a bit better, and then I'll show you one that we were able to get. But here is the acetabulum. These arrows here are denoting the indirect head as it's inserting onto it. This picture is one of those kind of panoramic ones. It also includes some other pieces of it as well, but you've got iliopsoas and you're starting to get rectus coming in as well. And then this was our image that we were able to get of our co-fellow. So we used a 2 to 14 megahertz probe, but you can see the acetabulum at the bottom and indirect head inserting onto it. And then since we're lateral, the muscles that we're seeing, so we've got glute min, which is overlaying it, and the TFL is the most superficial structure. Some papers have also talked about looking at the rectus femoris indirect head in short axis. It is pretty tricky to do, but again, you're in a similar position to before, but rotating that probe 90 degrees. And if you're able to get it, you can see here is the superior acetabular ridge. You've got an indirect head in short axis inserting onto it. So we also talked about the conjoined tendon. So that was this portion right here. And the setup for scanning this is going to be pretty similar to looking at that direct head. So you're just going to be moving a little bit distally. So this was a similar image to the one we had before. You can see the direct head is clearly inserting onto the AIS as it's traveling distally, and it changes structure here. We had mentioned before that in that prior image, the hypoechoic region, or that kind of shadowing that was going on corresponding to the indirect head traveling towards that superior acetabular ridge. They've combined by this point, and you're starting to see that conjoined tendon here. And on the next slide, we'll talk about how the conjoined tendon ends up becoming that rectus femoris muscle at the myotendinous junction. But you can kind of start to appreciate that right here in this section. So this is the myotendinous junction. So here's that image again, just a little bit more labeled. So I had mentioned that the direct head, the fibers travel, they form the superficial part of the conjoined tendon, and then form that superficial aponeurosis, which we're seeing right here. The indirect head, which we don't see clearly, but is coming from that superior acetabular ridge, joining the conjoined tendon, and then forms that central aponeurosis, which we're seeing here. We're starting to see those rectus femoris muscle fibers come into view as well. And if we move even more distal, this is an image from a paper, but you can start to see the rectus femoris muscle, and traveling in the mid portion of it is that central aponeurosis. Looking at that in short axis, I kind of went in depth about those axial views and what to expect at the different portions. So if we're kind of at that myotendinous junction, still in that proximal third of the rectus, we can see an image that corresponds fairly nicely with what you're expecting to see. So that central aponeurosis is traveling medially and it has a curved appearance, whereas the superficial aponeurosis is in the most superficial structure. And remember, this is a myotendinous junction that extends, a fairly long portion of the muscle belly. So we were able to get a video of that. So we're starting proximal and scanning distal. I'll tell you as you follow along. So this is going to be that central aponeurosis right here. And you can see it kind of becomes more pronounced as we start traveling distally. And notice how it travels along the mid portion or the medial portion of that muscle. So here it is. Right there is where it's ending. So definitely something you can appreciate on ultrasound. And again, there's pathology that goes along with this that we'll talk about later. So I'm going to hand it over to Jacob, who's going to start talking about some pathology that we see in the rectus femoris in adolescents and adults, and some ultrasound findings as well.
Awesome, David. Thanks. Hey, good morning, y'all. I'm Jacob, co-fellow with David over at Emory. We'll be talking about some pathology with the rectus femoris, the proximal rectus. We're going to talk about this in adolescents as well as adults. Starting with adolescents, you kind of can divide that into two types of injuries. You have your acute injuries, then your chronic injuries. And when we're talking about the acute injuries of the proximal rectus, we're talking about injuries at the weakest biomechanical point. This is at the apophysis. This is where the direct head inserts on the anterior inferior iliac spine and can result in an avulsion injury. And it's important that to know that this direct head inserts on this secondary ossification center on top of the AAIS, because that's what will pull off in these avulsion injuries. It's also important to note that remembering that the ossification of this area is usually it starts around 13 or 14 years old, and fusion's around 16 or 18. And that's important when we're, evaluating these adolescents that come in and understanding where they are in their growth phase and being able to correlate that with differentials. Now, these type of avulsion injuries can occur both on a normal apophysis or one that, has pre-existing apophysitis. These are going to be kids or adolescents that come in, they're playing a sprinting or a kicking sport like soccer or track. They feel like this pop over the AIIS area and have some pain there. The mechanism is going to be kind of a hyperextended hip on a flexed knee. It could also be a quick, sharp eccentric contraction of your quad, resulting in pain in that area and also some quad weakness. As far as the chronic injuries, we're going to show images of both of these. As far as the chronic injuries, this is going to be your more apophysitis picture. Just like you would have apophysitis in other areas of the body, you can have apophysitis at that ossification center on the inferior iliac spine. This is going to be due to chronic repetitive traction on that ossification center, resulting in chronic inflammation, developmental changes in this ossification center. Moving on to let's take a look at this on ultrasound. So our acute injuries, again, we're going to be looking at the direct head of the rectus femoris in a longitudinal plane as it inserts on the anterior inferior iliac spine. And then as you can see here, you have already this abnormal appearance of the anterior inferior iliac spine. And then you have the ossification center that is displaced inferiorly. You can see the direct head that's still attached to the ossification center, but that is not attached to the AIIS. And you can see that this is an acute avulsion injury. This is, I believe, somebody that presented within a week. And this is the acute, what it looks like acutely on ultrasound. So you'll see that the ossification center is detached there, and then the irregular AIIS. And then when we look at this at a healed, well, at about 5 months out, this is where this next image is from. So same injury, but now we're about 5 months out in the healing process. And you can really appreciate the abnormal is the image above and the normal is below. You can really appreciate this elongation of the anterior inferior iliac spine. And after it's kind of trying to heal and scar down, you can see the tendinopathic changes in the rectus femoral tendon as well when you compare that to the normal image below. And you can see this kind of widened growth plate as a result of this avulsion injury trying to scar down and heal. So, definitely a difference here. This is what it looks like about 5 or 6 months out from an avulsion injury. And it's pretty cool to appreciate and see those changes as that's healing. Taking a look at more of a apophysitis picture on ultrasound. Again, we're looking at this in a longitudinal axis. The direct tendon, the abnormal is above and the normal is the image below. Again, you can see this irregular growth plate on the AIIS where the ossification center is. You see that the ossification center is not avulsed off, it's in place. So this isn't an avulsion injury, but you have this widened growth plate. You have cortical irregularities along this area. And then you can definitely appreciate the difference in the direct head insertion. It's thickened, it's hypoechoic as compared to the normal. And it's really important that we're scanning both the affected and the contralateral side so you can really appreciate this, because this is a difficult scan to do. And if you can't really compare it, it might be hard to appreciate some of those, little changes on the growth plate and in the tendon. So it's always good to look at both sides. Getting into more of the pathology in adults. So you still have your acute and chronic injuries, although, growth plates are fused. So this is going to be more, the acute injury is going to be a direct head tendon rupture. Could also be an indirect head tendon rupture. Usually it's the same type of mechanism, a sudden jerk or on a sprint or a kick. The direct tendon is going to kind of give you more of that pop and that feeling in the AIIS area. And with the indirect tendon, there's reports that say the pain can be more anterior lateral or lateral. And even some of the literature suggests that the indirect tears may be even more common than the direct tears. There's actually a recent case series published this year in CJSM saying that based on the mechanism of action and then kind of determining whether there was a partial or complete tear. And it showed that more of the mechanisms that were running, sprinting, or kicking were more resultant in a complete tear versus the lateral movements and the quick side-to-side cutting is more resultant in a partial tear. So it was kind of interesting to see that. And then for our chronic injuries, these are going to be our tendinopathic injuries, like you would see in other places in the body, thickened hypoechoic, calcified tendon for tendinopathy. So let's get into some of those images. This is looking at the direct tendon and longitudinal axis again. and the abnormal is above, normal is below. And right away, you can see there is a complete rupture of the direct head of the rectus femoris. There's a nice hematoma in this area, and you can see the retracted tendon off of the A and not attached to the AIIS. So that's pretty nice to appreciate there, especially comparing it to the normal picture below. Definitely a complete rupture of this tendon with hematoma and retraction. Taking a look at the indirect head, which, as David mentioned, this is a much harder image to get. It's a lot more lateral than you think. So I would recommend practicing getting this on multiple people to kind of understand where this anatomy is. So when we look at the indirect head, this is also a complete tear of the indirect head. You usually should appreciate an acetabular, the rim below, but due to this hematoma and rupture of the indirect head, you actually have the obscuring of this acetabular rim and the retraction of the indirect head with that hematoma. So this is a complete tear of the indirect head. So it's a great picture and really cool to appreciate. But yeah, I do recommend practicing getting this because it's not an easy area to scan and get into plane. But once you find it, you kind of understand where it's located. And then kind of seeing a partial tear, which is even more difficult to really appreciate when we look at the indirect head and longitudinal axis. You can really appreciate that indirect tendon. Now we can see the acetabular ridge because there's no hematoma obscuring that, but you do appreciate some hypoechoic areas within the indirect tendon for sure. It's kind of hard to see, but there's definitely some hypoechoic areas representing some partial tearing in that indirect head of the rectus. And then moving on to our tendinopathies, again, looking at this in the longitudinal plane of the direct head. Here right away, you can see this pretty decent size calcification right next to the AIIS within the insertion of that direct head. You see a thickened hypoechoic area of the direct head tendon, and then this hyperechoic glob of calcification with some posterior acoustic shadowing from that classic calcific tendinopathy that you would find in a cuff or, a glute med. You can also get the same type of pathology on the proximal insertion of this direct head. And then looking at tendinopathies of the conjoined tendon, which is the direct and indirect head joining together, right away you see this thickened conjoined tendon, much thicker than we've seen in some of our other images. You still do see the direct head's attachment to the anterior inferior iliac spine, which looks decently normal. And you can see kind of the shadowing of the indirect head too. And as those two join together, you definitely have a thick a tendon here and consistent with tendinopathy. And of course, you correlate that with the clinical exam and the contralateral side and definitely appreciate this difference here. So this is tendinopathy of the conjoined tendon. And then getting into more of away from the tendon insertion pathology and more into our muscle pathology, we really have two types of injuries. You have a myotendinous tear an injury, or you have more of a muscle belly tear. And that's going to be talking about this central aponeurosis versus kind of the muscle belly. And we'll take a look at some images here, remembering our anatomy, the nice diagram that David had. We're going to look at this in a sagittal short axis plane, and you see the rectus muscle on top. And where that central aponeurosis would be, you have a small hematoma in that area where that indirect tendon turns into the central aponeurosis. Now you have our superficial aponeurosis that's intact. So this is a distal myotendinous tear of that central aponeurosis with a small hematoma within that area. And then looking at this in a longitudinal plane, you can see the hematoma where the central aponeurosis would be and our intact superficial aponeurosis. So distal myotendinous tear for sure on this. And you would compare this to the contralateral side. And then taking a look at the injury involving a muscle belly injury, looking at this at a sagittal plane. Now you see an intact central aponeurosis where that indirect tendon You have an intact superficial aponeurosis. So this is not a myotendinous injury, but more of a muscle belly. You see this nice size hematoma within the rectus muscle belly and diseased muscle here. Looking at sagittal, and then taking a look at this in a longitudinal plane. Again, you can appreciate this is a decent injury to rectus femoral muscle belly. Looking at this in a wide panoramic long axis view, nice sized hematoma and injured muscle belly with the intact aponeurosis.
All right, thanks, Jacob. So now that we've had some time to go over like what the possible the different possible pathology that can happen in this area, I'm going to go back to the case. It wasn't obvious before, hopefully it now is. So remember, this was a 15-year-old with anterior hip pain after kicking a ball, and he had tenderness over his AIIS. So initial x-rays showed an 8x27mm bone fragment with distal displacement from that AIIS by 36mm. Ultrasound confirmed an inferior displaced ossification center with an irregular appearing AIIS. He ended up opting for conservative management, so 2 weeks of non-weight bearing, followed by progressive weight bearing, and eventually returned to soccer after about 3 months. These are typically managed conservatively. Some talk about like 2 weeks of bed rest with the hip flex to 70 to 90 degrees to give that tendon and the avulsion a better chance of healing. There are also thoughts about maybe surgical management, depending on how far it's avulsed, but most of what I've seen is that conservative management works fairly well. This was his initial x-ray, so you can see that bony fragment displaced. And the corresponding ultrasound shows that avulsion. The rectus femoris is here, AIIS is here. This is with a 6 to 15 megahertz probe. And the contralateral side, like Jacob was saying, always comparing it to that, looks much more intact. We didn't have his 3-month post-injury ultrasound. We had x-rays though, and you can see how much larger that fragment is. It was displaced. And using that image from the paper that really shows how much it grows over time. So the growth plate is still widened, but you do have that new bone growth as that fragment kind of expands back towards where it originated. These are our references, and sorry, I think we ran a little bit over, but we'll open it up for some questions.
All right, thanks guys so much for presenting that. You guys had some great images of the rectus femoris. Just as a reminder, as we approach these clinical problems, it's you had put up a slide initially, one of your first slides that kind of showed what a complete anterior hip exam is. And I always just think, especially as we're learning ultrasound, maybe as residents or fellows or early in our careers, or if you're picking up later, it's really important to kind of think about the ultrasound as an extension, of our examination and our ability to kind of sort through some of our differential diagnosis. So in this, particular individual, certainly you'd be wanting to look at, the femoral head neck junction, and, perhaps even a little bit of dynamic imaging in that area, making sure that you're taking a look at the labrum, iliopsoas, sartorius, TFL, potentially dynamic scanning, maybe the lateral femorocutaneous nerve. Sometimes you'll take a look over at like the pubic rami, pectineus adductor area as well, if they have more medial pain. And so just kind of keeping in mind that comprehensive, ultrasound examination of the anterior hip, is quite a few structures beyond the rectus femoris. Going into this, I always think about these avulsion injuries and wonder, why aren't we spending more effort taking a look at these with ultrasound? Is there really even a role for getting an MRI in one of these? Will ultrasound give us that same information? One of the images you showed, I think it was maybe from a paper, you could really appreciate that there's like a donor site, and then there's kind of that avulsion fragment. And if you kind of just squint your eyes a little bit, you can see how that, avulsion fragment would fit into that donor site. And I think you can get a pretty good idea of how much displacement, there is with these under ultrasound. And that's really, one of the key features of these is how displaced they are. And so I think ultrasound can be a really good test for that, because, your hip x-rays showed it pretty well, but a lot of times the hip x-rays are, not quite as revealing as we'd like them to be for something like this. And so I think there definitely is a complementary role of ultrasound for these sorts of injuries. Doug or Ryan, do you guys have any comments that you want to mention?
Yeah, thanks. Thanks, guys, for presenting. This is Doug Hoffman. Just a couple of things. One, just about the anatomy, in that you don't necessarily see individual fibers, but the iliocapsularis muscle, which is under the rectus, has a different longitudinal plane than the rectus, but its insertion is right where the reflected head is. So just something to keep in mind, that that's not confused with the indirect head of the rectus itself. So it kind of goes right in between where the direct and indirect head are, and inserts on to the acetabular rim. I think as Brennan mentioned, when I approach someone with a potential rectus femoris injury, that's an anterior hip exam. And so there's a lot of obvious structures in the anterior hip exam, the joint, the labrum, as Brennan already mentioned, the muscles and the front of the hip. A couple other things to consider, and I always include the gluteus minimus as part of my anterior hip exam. And I've had a number of cases where if I didn't look at the G-min, I would have missed it. And at times it can present as anterolateral pain, at times as lateral pain, but I have probably a handful of cases where someone came with anterior hip pain, and in one or two cases rule out rectus femoris or iliopsoas abnormalities, and there was the G-min. And so I would consider putting the G-min in your anterior hip exam. And as far as the rectus itself, because it's part of the anterior hip exam, and I do an anterior hip exam when I do a hernias exam, really with any hip exam, I see a lot of rectuses and insertions, the direct head, and you can get changes in that direct head that are asymptomatic, small calcifications and just attritional changes. And certainly if you're scanning someone who has had a direct anterior hip arthroplasty, they have to take the iliopsoas and the rectus femoris and pull it pretty hard with the retractor out of the way. So that's naturally going to look beat up. And so that's something else to keep in mind. And then finally, when I'm looking at pathology of the direct head, particularly tendinosis, I really scrutinize carefully with the short axis image, because that long axis image oftentimes is not a complete, you see anisotropy from the reflected head. And so by going short axis really carefully, then you can just stay on the fibers of the direct head and get a better sense of whether they are tendinopathic or not. Brendan or Ryan, do you have anything to add about the protocol?
Yeah, Doug, the G-min is a great addition. And just when you review the anatomy, the glute tendons, the glute min is really actually quite anterior, runs right next to the hip joint. Certainly something that we should be looking at. You guys mentioned the indirect head and how difficult that can be to image. And I agree with you. I think that's probably one of the hardest things that we have, as our fellows and residents are scanning. It's one of the hardest things to get them to image, adequately. And, really, I think one of the keys to that is you have to rotate your transducer quite a bit. So it's, almost perpendicular to the direct head by the time you get to its insertion. And you really have to be thinking of shooting your transducer almost from like lateral to medial instead of anterior to posterior. And when you get that rotation and then you slide and then you're aiming in towards the hip and not posterior towards the table, that's when you get those good images. And you really should be able to get a nice clean image of that tendon coming down to that superior acetabular rim. And, once you learn how to image it, it should image just as nice as, any other tendon for the most part. And then the last thing I'll say is, one thing with these folks and these avulsions that you have to, you can always look for as well, especially if you're seeing them later on, is maybe some subspine impingement. And so in people who have some sort of hip impingement symptoms, if they're sent to you for that dynamic exam, or even sometimes if you're seeing them for, maybe like a ropivacaine challenge to try and figure out where their pain is coming from, you should look at that AIIS morphology and look for hypertrophy of that particular osseous structure that can predispose to that subspine impingement. So that's just another thing that you can, help out with as you're looking at these folks. I think that's all I have. Ryan, I saw you unmuted yourself for a second there.
Oh yeah, no, I think you and Doug commented on pretty much every comment that I was going to make. I think the only other comment, I guess, to highlight, Brennan, the point you made about the challenge with imaging this, it is really tough. It can be really hard. That indirect head comes off like at a 45-degree angle and then ends up, almost in a, like you mentioned, anatomic axial plane. So when you look down at the patient, it can be somewhat confusing because of the orientation of that tendon. The only, I guess, other thing that I would add is, we're talking about this proximal tendon up at the level of the acetabulum, at the level of AIIS, but you guys, like you alluded to, this indirect head will continue downward distally as a central tendon, down near the junction of the middle and the distal third of the muscle belly. So just make sure you follow this all the way down and scrutinize the tendon all the way distally. It's not common, but I have had a couple athletes in the past couple of years that have had more of a mid-substance or distal central tendon injury. And yes, they hurt down there, but they also have referred pain up near the AIIS. I'm not, entirely sure how to explain that, but it's happened a couple times. It's a real thing. So just make sure you said evaluate and scrutinize the entire extent of the central tendon. Otherwise, good job, guys.
All right, fantastic. Thank you so much.